Before we start, we just want to thank you for being here. Today, we're going to ask you questions surrounding vaccination hesitancy, vaccines, and public health. So, again, thank you for being here. We really appreciate it.
I'm happy to be here.
Thank you.
So starting off, I just want to ask you, could you share a significant breakthrough or achievement in the field of childhood infectious diseases prevention through vaccines that you could have been involved in or witnessed during your career?
Well, I would say the biggest thing that I've witnessed has been the very effective control of measles. It was, I mean, partially under control before my time. Before we had a vaccine first available in 1963, pretty much every child got measles. I mean, there were about 500,000 cases reported a year, but it was underreporting. So probably, I mean, pretty much every child, every person got measles, and there were about 500 deaths. But there were a lot of complications too. About 30% of measles cases will have some sort of complication, diarrhea, otitis media, pneumonia, encephalitis. And progress was made before my time with vaccines. We saw a pretty substantial reduction. Um, Really, where we started to see problems was in 89 through 91. There was a big resurgence of measles, and it caught people by surprise a bit because it looked like coverage was pretty high across the country. And measles vaccine is pretty effective, like 93% for one dose. And when that was investigated, they found that there were pockets of very low immunization, in particular in cities like Los Angeles and Philadelphia and around immigrant populations where you had very low coverage. And there was a huge resurgence of measles in 89 through 91. A lot of kids got hospitalized and some died. It was really pretty terrible. But that crisis was also an opportunity. And based on that resurgence, a lot of the infrastructure and the systems in the US for vaccines were really built. We started measuring vaccine coverage much better, and that started the National Immunization Survey, so we could see trends over time and what vaccine coverage looked like among young kids. It created the Vaccines for Children's program, which purchases about half of all pediatric vaccines. There started to be a closer look at school immunization requirements, and they found initially that having a requirement mattered, as did enforcing that requirement. And states started to enforce their school immunization requirements. And all of this led to much higher vaccine coverage. And we eliminated measles. Now, elimination means that there's not indigenous transmission most of the year. It basically means it's been well controlled. So there was just a huge success. We also went to a second dose of measles vaccine because we saw that 93% is really effective, but that 7%, given measles is so infectious, was still causing outbreaks of disease. So with all of that, we really, really controlled measles. And I would say in my time, that's one of the huge success stories. But that's being threatened now. And while we've quote eliminated it in the US, and I put a quotation around that because we do have measles outbreaks. And typically somebody comes from a community that has lower vaccine rates, which is usually because of vaccine refusal, and they go to a country where there's a lot of measles, which, I mean, like, Africa has tons of measles. It's tragic. It's a huge missed opportunity, but they're actually more likely to travel to Europe, for example, where there is measles, and then they'll bring it back. Or somebody from Europe will go to one of those communities. The outbreak in Disneyland got a lot of attention. Um, and so these are international importations. They're not like people coming over the border from the South that are bringing measles. They're more US travelers or international travelers, and they cause outbreaks in these communities where people aren't vaccinating, where they're refusing vaccines. And, we almost lost measles elimination status right before COVID. Um, and I suspect if we hadn't shut down the world, we probably would have. So there's just been reoccurring outbreaks of measles, and I worry that's going to get worse. So, I mean, it's a huge achievement. It's a huge accomplishment. not just that we've controlled measles, but we've built all this great infrastructure around childhood vaccines. We don't enjoy the same infrastructure for adult vaccines. And if we did, COVID probably would have gone a lot better. Um, but yeah, I would say that measles is probably measles control and building that immunization program was the big vaccine success that I've seen in my career.
Thank you.
This is a follow-up question or something. So as far as like the infrastructure that goes along with like children being vaccinated, what's the major difference between what you see with children and then adults? So like why, it's more likely that like with COVID, why it's more likely that adults, the vaccinations are lower, if that makes sense, than with children.
I mean, there's a lot of reasons probably why coverage is lower, and specifically with COVID. But when I was referring to the infrastructure for children, so for one, cost has been eliminated as a barrier for childhood vaccines. If the ACIP recommends it universally, then it kicks in an entitlement program called Vaccines for Children. And Vaccines for Children purchases vaccines using taxpayer dollars. It doesn't require a separate appropriation. So it's an entitlement program. And it's for children that are uninsured or underinsured or Native American or Alaskan Native. But basically, everybody that doesn't have insurance that would pay for it, the VFC program pays for it. And that's about half of kids. There's also a requirement through Obamacare that if you insurance has to cover vaccines first dollar coverage. So cost has been removed as a barrier. That's not true for adult vaccines. It was true for COVID, and we'll see what happens. But typically for adult vaccines, they're not lots of people. Think about how many uninsured people we have in this country. I mean, it's like what, 40 million or something? And people are underinsured. So cost is frequently a barrier, you know. I mean, a flu vaccine is less expensive than, say, a shingles vaccine, but cost is also a barrier. We also do a much better job of measuring vaccine coverage for children through the National Immunization Survey. We don't have nearly as good means. And then there's also a program called 317 funds, which CDC gives to states to run childhood immunization programs. So that gives them an operating budget, sometimes FTEs, and every state receives these funds. They have an immunization program manager, and then they, do all sorts of things within those states for childhood vaccines. There's no program like this for adults. And state immunization programs, can direct some of their limited resources to try to work on adult issues a little bit. It's just not funded. So you don't have the cost still is a barrier. You don't have the strong support from states. You don't have, measures of immunization coverage. So those are the things at the federal level. I mean, there's lots of differences between adult vaccines and childhood vaccines, that make that more complicated, differences in terms of clinicians and practices. Generally, pediatrics is really supportive of vaccines because, they know the benefit of them. Whereas as you get into adult providers, children tend to go for regular visits, especially when they're young, where adults often don't. So there's a lot of differences there too between the diseases and the vaccines and how people enter the healthcare system.
Okay, I have another question for you. Given your expertise in epidemiology and health policy, what do you see as the most pressing challenges in vaccine acceptance and coverage today? And how do you believe they can be addressed?
Well, I really worry about the post-COVID world. Um, before COVID, well, a lot of people didn't even know what public health was. And when you ask people, they would be like, oh, those are those free clinics that poor people go to. And they really didn't understand public health. But if you explain to them public health, I think people were pretty favorable. And vaccines were largely apolitical or they were bipartisan, maybe is a better way to put it. And both. I mean, vaccines had managed to largely stay out of the political discourse. And both parties have historically really supported vaccines. Um, and so this has changed. COVID has become so politicized, and people are defining themselves by their vaccine status. and politicians have become polarized. And you have, like, I don't know, certain news channels that run repeated things that scare people, and we've really potentially done a lot of damage. And I think also with public health, I don't think public health, the reputation of public health among a substantial sub portion of the population, has really declined. And people hear public health and they're like, oh, that's the person who's going to tell me I have to wear a mask, or they're going to close my business. And so I think that the potential impact of all of that on vaccines is tremendous. Um, right now, we're seeing small drops, small changes um, in maternal immunization, or a bit more exemptions to school requirements. It's fortunately not as profound as I thought it might be, although the data yet are still coming in, and it'll take time to really see the impact. But I think it's a huge problem for vaccines. We don't win if 50% plus a hair or the electoral college votes for vaccines. We typically need like 95% plus compliance to really control a disease. And you're not going to get there when it's polarized.
So, in your extensive experience, could you highlight a specific example of how your work has contributed to improving vaccine safety or vaccine informed decision making for both healthcare providers and patients?
Um, I think some of the work I'm most proud of was for H1N1. I was in the government. I was in an office that doesn't exist anymore. It was called the National Vaccine Program Office, and I was the director of vaccine safety. So this is an office where, by statute, our responsibility was to oversee vaccine activities across the federal government and work for non-federal partners. So, kind of a quarterback policy office between NIH, FDA, CDC, HRSA, Indian Health Services. These are all HHS agencies. And then working with departments of defense and veterans affairs, and then non-federal partners from industry, academia, state health departments, professional medical associations. Basically, the goal of our office by statute was both to control disease through vaccines and reduce adverse events from vaccines. So that was our responsibility, though we didn't actually have authority, which is kind of a long story, but we reported to the Assistant Secretary for Health. And during the Clinton administration, that position was moved to the side. So the Assistant Secretary for Health used to have authority over the CDC director and NIH commissioner, but that didn't happen anymore. So it was a position of responsibility absent authority, which in general, you want to avoid jobs like that because it means you're supposed to get something done, but you don't have the tools to do it. But for H1N1, the secretary came in and said, we're in charge of vaccine safety. So we were kind of deputized, so to speak. So my job was to oversee the H1N1 vaccine safety program. And we had a new president, Obama, who was elected on healthcare reform. And his first crisis was H1N1. He knew either already or once briefed that the last time we vaccinated everybody for flu was 1976, and it was just a disaster. The pandemic didn't happen, but the vaccine caused Guillain-Barré syndrome, which is a pretty serious neurological condition, and people died from the vaccine. The CDC director got fired, the Surgeon General got fired, and some people say that's why Ford didn't get reelected. But probably there's a lot of reasons why Ford didn't get reelected. Anyway, Obama knew clearly that if H1N1 went south and the government can't run a vaccine program, then healthcare reform was dead. And the biggest risk with that vaccine program was another safety problem, a real problem like in 76, or potentially just a coincidental thing that went crazy on social media, which he saw the potential for. And he had a new secretary and two new assistant secretaries, which he just said, you got to make this work. So they came to me and said, what do you need? We got to get vaccine safety right. So it was a really cool experience. We did some really cool stuff. We built a very large active surveillance system, putting 40 million people under active surveillance in about 45 days. And which is really pretty amazing. You know, now it's all anonymous. When I say active surveillance, I mean we got counts of medical outcomes in a way that we could do the epidemiology we needed to do, but it was all anonymous and de-identified. And then we tweaked the capacity in other agencies like CDC that had active surveillance. You really need good active surveillance, right? Because that's how you figure out if something happening after vaccines is just by chance or caused by the vaccine, right? So if you vaccinate tens of millions of people very quickly, every bad health outcome that would happen will, and it'll seem like it's around the time of vaccination just by chance, right? If you vaccinate everybody today, every bad thing that happens tomorrow happened a day after the vaccine. Heart attacks and strokes and cancer diagnoses. And you need to quickly figure out, right? Is it just by chance or is it caused by vaccines? And having big healthcare databases really, really helps do that quickly. So CDC had some capacity here, really good data that they knew really well. It's just it wasn't big enough. And then like Indian Health Service, VA, DOD, we brought everyone together. Everyone used the same protocols. We created an external group that reviewed all the data every 2 weeks. So we had a all hands on deck approach. We had more good data than ever before in vaccine safety. Everyone was using the same protocols, so we could compare data. We could, we shared it regularly with ourselves as feds, but then with external experts. Once a month, they put out a public report, and it all worked really well. Fortunately, the vaccine was very safe. We had some early signals for Guillain-Barré syndrome, Bell's palsy, and ITP. The Bell's palsy and ITP turned out to not be real. It was a spurious finding that was covered in the New York Times, but it was like, fifth page. Basically, a bunch of external experts are looking at all the safety data, and there's a couple weak signals that they're investigating. So it was all transparent and public, and we had tons of data, but it wasn't like scary for people. In the end, we combined data across all these different data systems, and we found a very small risk of Guillain-Barré, about 1 to 3 cases per million people vaccinated. So that's, it's a really small risk. And because we had such good data, we could define that. So it was a system that worked. It was a process that worked. And I say it worked because if there would have been a problem, we would have been very, very likely to identify it. Even a very rare one like Guillain-Barré, we did. And spurious or chance associations were addressed. And, when you look at H1N1, while people were worried of a safety problem, it really didn't happen. I think we maintained public confidence as best we could. We did other things. We did tabletop exercises with the media. So we brought all the top media outlets together. We did this 3 times, and we brought in like the CDC director and leadership at HHS, and we worked through scenarios where they would ask us questions and we would give them our responses. We published a paper in the Lancet where we described the background rates of all these different diseases in different populations measured in different ways. The point being that this will happen after vaccination. And we gave it to them. And then we went through a scenario where 2 cases of Guillain-Barré within 2 weeks of vaccination popped up. And, what are you going to ask us? And the New York Times reporter would ask us questions. And that both prepared us, but we also prepared them, right, for what was going to come. So when they did see a couple cases, they didn't freak out. We developed our plans across government and made them available publicly. We published them in pediatrics, and we let health departments and docs know what we were doing in advance. And then our reports every month that were public were really broadly shared domestically and globally. So we just had a system in place which was based on rigorous rapid science, objective science. We had external review from people who were top-notch scientists, but were like super squeaky clean in terms of conflicts of interest. I mean, I put them through the ringer with our attorneys. just so there was nothing that looked weird. Um, and I think it all worked really well. So it was a really, really cool opportunity to try to have an impact. Unfortunately, that job doesn't exist anymore, and that office doesn't exist anymore. And like for COVID-19 vaccine safety, there wasn't just one person in charge. I can't tell you who was in charge. Each agency kind of did their own thing. And yeah, so it was a great experience. It was great to have had that opportunity.
So you mentioned that you worked with various public health authorities at different levels. Could you share a particular impactful collaboration or project that you've been a part in strengthening immunization programs or pandemic planning?
I mean, I do a lot of work in that space.
Mhm.
Mm. So here's an example, and um, one which your professor was a part of. So early in COVID, as we were, if you look at Operation Warp Speed, right? The goal was to make a vaccine available for everyone who wants one within a year. That
Mhm.
was, say, the goal of Operation Warp Speed. And let me just say, that was a great idea. And President Trump putting all that money into that and it was fantastic. The problem is it's a bit short-sighted. It's only part of the way there. And they had a vaccine available for everyone who wanted one within a year. But the problem is you need to A, have safety surveillance, and B, people have to want them, right? Because you could vaccinate 100 people and call that goal succeeded and have no impact on the pandemic. So the work to understand what people were thinking and to try to communicate with them and to prepare local public health just wasn't a part of that whole Operation Warp Speed. And the feds didn't take that part with the needed um, I don't know, with as much effort as they did developing and manufacturing vaccines. So we reached out. We were having conversations with NATO about this. NATO is the Association for City and County Health Officials, so it's the local public health. And we went to Robert Wood Johnson and spoke to their deputy director and said, we got to figure this out quick, and we don't have time to wait for the feds to do this. And I think it's the fastest we ever got money. Like we gave them a proposal a few days later, and within a couple weeks we had a contract. And our goal was to inform local public health. So we did a whole bunch of community meetings. We worked in vulnerable communities, African American, Hispanic, Native American, and we worked with vaccine hesitant communities. And we did a whole bunch of community meetings before the vaccines were rolled out and then as they were being rolled out. And we also did two large population surveys. And each time we did this, um, and again, your mentor was a part of this in New Orleans, but every time we did this, we would really quickly put together an actionable report for local public health. So we, for example, did I think it was 42-hour meetings, community meetings, and we coupled that with a survey and just tried to figure out the question we were trying to get at was how can local public health meet your needs? So these meetings were not about telling people to get vaccinated or convincing them to get a vaccine when it was available. The question was, how can your local public health serve you? And we really quickly pulled that together, shared it with through NACHO and other partners to all of local public health so that they had information about what could be done from the perspective of the public by them to help people make informed COVID-19 vaccine decisions. So, that was pretty cool. It was fun. And we worked with all sorts of local public health.
So follow-up question, out of all the projects you've done in your time as your job now, what has been your favorite project you've ever done? Like ever?
Well, that's a really big one. And I've had multiple jobs. Just in my current job or in any job?
Yes. I would say current job for now.
Um, well, the one I just told you about was definitely a really fun and exciting one. We developed a tool for personalized
Mhm.
communication. It's a website where you start by getting asked some basic questions about what vaccines you're interested in, and your language and your age, and what concerns you might have around vaccines. And then it tailors information to you. So they're basic diagnostic questions. And the information is a mix of personal narratives and credible sources, and then animation covering the different issues. And we started this around maternal and infant vaccines, and we showed among pregnant women through a fairly large RCT that we could improve vaccine uptake for flu vaccine in pregnancy among pregnant women and their family and friends, and then also decrease vaccine concerns for children a year after birth. And then we expanded it for COVID, and we've now got it for vaccines across the lifespan. So we have, I don't know, a 10-hour movie basically in little pieces, 20 seconds, 2 minutes, probably 3 minutes is the longest. And nobody wants to watch a 10-hour movie, right? So how you answer, not even me, although I've watched it in pieces many times, but how you answer these basic diagnostic questions means that you get 4 to 8 minutes of that 10-hour movie, which is really, it's going to hopefully address your concerns and give you the information you need in a way that is useful to you. And we're now expanding that for other populations. We're doing more evaluations. We're just submitted a grant to adapt it to South Africa. So we're trying to scale it up as well. So that's an area that I'm excited about.
So, in your opinion, what are some of the key global policy considerations that should be taken into account when making decisions about vaccine policies, when balancing the reduction of myocarditis and pericarditis with potential risk and cost to population level immunity?
Well, so I'd be a little bit careful with the population level immunity because, if the vaccines aren't doing a great job of preventing disease, we're not going to get really high levels of populate. I mean, we'll get some levels, but um, it's a big question, myocarditis and pericarditis, right? This is a rare outcome from mRNA vaccines. The highest risk is among young men and older boys after the second dose. The risk is somewhere between 1 in 2,500 and 1 in 10,000 doses for that highest risk group after the second dose. It's a pretty wide range. In general, vaccine-induced myocarditis is less severe than other causes of myocarditis. Often, about half the time, they get better pretty quickly. We're still doing long-term follow-up. There have been some deaths reported. Um, I think that the Moderna probably has a higher rate than Pfizer. But when I say I think, I mean the data is not as clear as it should be. I think by separating doses a bit more, that probably reduces the risk. Um, but I say I think because I don't think the data are adequate to really know for sure. So at the end of the day, it's about balancing risks and benefits. And as long as we see COVID widely circulating, the benefits still outweigh the risks. In fact, we have a DRPH student that just published a review in the American Journal of Epidemiology, and he did it by QALYs, quality adjusted life years, so you can compare good and bad things and risks and benefits, and did it by age and by gender, and the benefits outweigh the risks across age and gender, even among younger males where their risk of disease is low compared to other groups and their risk of myocarditis is high. The benefits have still outweighed the risks. However, I would really like to know if the Pfizer has lower rates of myocarditis than Moderna, then for people at highest risk, let's use Pfizer. And if spreading out the doses helps a little bit, well, we got to do that too. So I think we need to figure out, why is this happening? Is there a way to prevent it? Is it a random event? Probably not. Is there a genetic basis? So I think, we need to keep in mind the benefits outweigh the risks. So with the current vaccines, the recommendations make sense. Even again, among the groups at highest risk for myocarditis, and lowest risk, one of the lowest for disease. But whatever we can do to lower that further, whether it's using one product over another or spacing it out more, or if we can understand the biological mechanism and figure out what that 1 in 25,000, 2,500, or 1 in 10,000 in some way prevent that, that would be really good. I'd also like to have a tighter risk estimate because that's a pretty wide range. So I think there's ways that science can help us, and it should, and that should be a priority. And ultimately, it's a risk benefit decision, right? That's what it all comes down to. You can't look at either in absolute terms. It's only in comparison that you can make an informed decision.
I have one more question, Dr. Salmon. So, as future healthcare providers that are currently working in healthcare settings right now, we often come across patients that are hesitant to receive vaccinations, whether that is due to, scare tactics, fake news, or just, fear of getting vaccinations. What is a good response to tell our patients whenever we hear this or see this?
Well, I'm glad you asked me that. We have a CME module which teaches clinicians how to talk to patients. Um, and if you want CME credits, go through Johns Hopkins Medicine. If you want to see it without CME credits, I'm happy to share it with Sarah, and you can see it. But this is what clinicians should do. First, when someone comes in, you want to start presumptive. Um, in other words, oh, it's October, it's time to get a flu vaccine. Your presumption is they're going to follow the standard of care and they're going to get vaccinated. And that really makes a difference. That would be in comparison to, oh, it's October, do you want to get your vaccine? Right? And that would be a participatory approach. But it's a standard of care. Your presumption should be they're going to follow the standard of care. So you start with a presumptive approach. Hey, it's October and we'll give you your flu vaccine today. And if they raise a concern like, oh, I don't want to get the flu vaccine, I'm afraid it's going to give me the flu. So then you want to pivot to, and we describe it as a 5-step process. And you want to start by connecting with the person and creating some level of empathy and trust with them. So, for example, let's say somebody says, I'm worried about getting flu from the flu vaccine, which, I didn't just make that up. That's like a really common concern that people have. So you want to start by connecting with them. But what you don't want to do is you don't want to validate the myth. So you don't want to say, I understand that you don't want to get the flu vaccine because you don't want to get the flu. Because even if you go to debunk it afterwards, simply by restating it, you'll end up validating it. But you want to connect with them. So you might say something like, hey, I understand you don't want to get the flu. I don't blame you on that. The flu is absolutely miserable. And you know what? A lot of people think that the flu vaccine can give you the flu, but actually it can't. It's not a live vaccine, and you can't get the flu from the flu vaccine. But you could get exposed to the flu, get the vaccine, and before the vaccine works, get the flu. That's possible. And also, the flu vaccine, when you get an immune response, it can make you achy, it can make you tired, it can even make you feel like flu-like symptoms. It's not the actual flu, but it is showing that your body's working. So what I just did is I connected with them over our common value to avoid the flu. I didn't reinforce the myth, um, but I did answer their question, and that's not a crazy thing for people to think, right? And then once you've addressed the concern, you want to pivot to the risk of disease and talk about vaccine effectiveness, and then give a strong personal recommendation. So after pointing out that you could get an immune response or you could get the flu before the vaccine works, you want to say, the flu can be really serious. I mean, people can feel sick for a week or two. If you're elderly, if you have health conditions, a lot of people die of the flu. Or you can get it and you only get a little bit sick and you give it to a family member and they get really sick. And you know what? The vaccine works pretty well. I mean, it's not the perfect vaccine, but typically 50, 60% of people will be protected. And if you do get the flu vaccine, if you do get disease, it'll probably be milder. You'll be less likely to be hospitalized, less likely to die. Um, so, I tell you what, I get my family vaccinated, and I get vaccinated every year. And so you end with a strong personal recommendation. So that's the approach that we teach for clinicians to talk with patients about vaccines.
That definitely helps. Thank you. Because we're all immunizers. We got certified through Xavier, so I know we all give a lot of shots. So that definitely helps whenever talking to patients. Thank you.
You're welcome. It's really important. The healthcare provider, the clinician, is the number one source for vaccine information. Even among people that don't get vaccinated, that's who they trust most. And there's a lot of information out there. There's a lot of misinformation out there. Our website, vaccinesafety.edu, has tons of information, evidence-based, systematic reviews of safety topics. We have a book that covers this, and then a module that teaches clinicians on how to talk to patients. So making sure that you're informed and knowing how to talk to patients about vaccines really, really helps. And then, assuming it's true, if you vaccinate or you vaccinate your kids or your family members, tell them that, because that really matters, because they look at you as an expert. And if that's the decision you made for yourself or your own family, it makes people more comfortable to make that decision.
Well, thank you so much for taking the time out and talking to us about what you do, how you do it, and how it gets done. We truly appreciate it.
That's great to talk to you.